Hello, and happy Sterile Processing Week, everyone. This week is dedicated to recognizing the vital role sterile processing professionals play in patient safety and quality care. Every instrument that passes through your hands directly impacts patient outcomes, surgical and procedural success, and infection prevention. This is your week to be seen, celebrated, and reminded of the essential impact you make every single day. So thank you for all you do. I'm Diane Darga. I'm a clinical educator with Healthmark, and I have 30 years of nursing experience, 20 of which have been in GI and endoscopy related fields. I've done pretty much everything you can do in endoscopy, except for the doctor part, of course. And I've spent the last 10 years or so in management and leadership of endoscopy departments. Today, I'm going to be talking about the updates regarding the Olympus Endoscopy Products. There's been some urgent alert letters that have gone out, and I'm going to cover the content of those letters just to make sure that you guys have the latest and greatest information. Here's our objectives for today. We're going to review the endoscope reprocessing cycle, summarize the background of infection prevention concerns related to flexible endoscopes, review the basics of endoscope anatomy, taxonomy, uses, and differences. Discuss 3 of the most recent urgent alert letters from late 2024 and mid-2025. But first, we're going to go through some endoscope reprocessing basics just to make sure we're kind of all on the same level playing field here. So we're going to start with the reprocessing cycle. And I'll whiz through this one here because I know looking at slides like this is not super exciting, but you start up at the top for the HLD part where it says pre-cleaning or the point of use cleaning. Then of course you move into leak testing, then manual cleaning, then rinsing after the manual cleaning, cleaning verification and inspection, and then high-level disinfection, drying, storage. And of course, to the left there, you see what the process would look like if you were going to be sterilizing instead of high-level disinfecting. And here's the reprocessing cycle in pictures. I thought this might make a little bit more of an impact and make more sense to everyone. But you can see the point of use treatment is what occurs in the actual procedure room. And usually that's done by either the nurse or the technician who are assisting with the procedure. And it just, encompasses basically sucking some fluid through the scope and using the air-water cleaning adapter, wiping down the insertion tube with a sponge similar to the one you see pictured here. And then, of course, writing down, communicating the time that the point of use treatment was occurred and making sure that that gets communicated to the reprocessing staff in the reprocessing room. Then, of course, there's the soiled transport. You got to make sure that it is very obvious that it's soiled. There should either be a sticker or a big bag over it, something like this in your rigid container. And then you're going to move into the leak testing. And there's various different kinds of leak testers, so that process looks a little different depending on what you're using, but it's super, super, super important to be doing a leak test. And then we'll switch to the manual cleaning part, of course, where you're actually washing the scope in the sink, doing some flushing and some suctioning, and so on and so forth. Then once you take it out of the sink, you are to be visually inspecting it, and not just with your naked eye, ideally. Hopefully you're using some really good magnification and some extra good lighting as well. And then in addition to doing the visual inspection, for the high-risk scopes, it's really important to do the cleaning verification, some sort of method of cleaning verification that can be one of the tests that you can just look at the color change. You can test for protein, you can test for hemoglobin or carbohydrates, or you can test using an ATP meter of some sort. After that has passed the test, hopefully, you're going to move on into the HLD or sterilization part. And then after it's done being HLD'd, you're going to dry it very carefully. This is a very important step. And then the storage part is also very important to make sure you're not recontaminating it after you've just done all the work to get it so nice and clean and high-level disinfected. So here's some background of infection prevention concerns related to endoscopes. So fact, more healthcare-associated infections are linked to contaminated endoscopes than any other device. I was really shocked to hear this when I heard it for the first time. And interestingly, there's multiple studies that come from multiple countries that have documented a failure to comply with the established guidelines for HLD. Now, to me, this means that this is not a person problem or a people problem. This is a process issue. So then there's also many studies reporting on infections and outbreaks even when there are no known breaches in processing, which pretty much highlights the complexity of the device as the problem, as the barrier to getting things clean and highly disinfected. Then, interestingly also, due to the latency period or the period of time between the exposure to the infection and the signs and symptoms of the infection, many infections go undetected, which leads to a massive amount of underreporting, which impedes our ability to understand the full magnitude of the problem. So we really don't know how big this problem is. Here's some common threads that are noted that increase infection risks. And they're complex endoscope design, which we talked about a little bit, making it difficult to properly clean and dry properly. And then poor adherence to the manufacturer's instructions for use as far as the cleaning instructions go, and maybe not as good of training as there could be. Unclear or difficult to understand manufacturer's instructions for use. Sometimes they require extra clarity. And then poor handling and storage practices. Sometimes people are not wearing gloves when they're handling the scopes, which is kind of endoscope 101 handling for me, is you absolutely should be wearing gloves after performing hand hygiene every time you're handling a scope. And then contaminated AER equipment and rinse water after high-level disinfection. There's been several studies that have pointed to the AER equipment and lumens within that machine having biofilms on it. And of course, that's going to just pass it right along to the endoscope, or contaminated rinse water. So these are things that a lot of people don't think about, but that have been shown to be problems in some places. And then incomplete drying of internal channels, not fully drying it until they are bone dry. This is really an important thing to do, because if you don't get them completely dry, the bioburden or the bacteria that are in there can multiply exponentially. And it happens very fast. You can have over 2 million colony forming units in less than an 8-hour day. The use of damaged endoscopes. Now, any kind of damage that you have on any kind of a scope surface is going to act like a reservoir for bacteria and gunk and whatever to get caught up in there. And so if we don't know that we're using damaged scopes, we don't know that this is happening, and it makes it really hard to clean. And then the use of simethicone is another really big issue. I know the doctors love it. It really works great for getting rid of those bubbles, but during the procedure, but it really sticks around on the endoscopes, and it's incredibly difficult to remove even after multiple rounds of HLD. And then delayed reprocessing. That's another very important thing that's getting a lot of press lately. Ideally, we have this golden hour. The scope should be basically taken from the procedure room and hit the manual cleaning sink, and ideally the high-level disinfector machine within 1 hour from exiting the patient. Anything beyond that is considered delayed reprocessing, and there's additional instructions and basically soaking instructions that you need to follow according to the manufacturer's instructions. So I know I was mentioning biofilm in a couple different slides there, and I want to explain how biofilm actually forms. And it's basically forms when bacteria attach to a surface and then they multiply. then they begin to produce this slimy coating that helps them stay put and protects them at the same time. It's this sticky and slimy stuff that's biofilm. And biofilm is a community of bacteria that kind of gel together again, like with this slimy substance, and they use it as a method of protecting themselves, making them harder to kill with antibiotics and disinfectants. And in the upper right-hand corner, you can see what a biofilm community looks like. Kind of disgusting, right? Now here's some noteworthy outbreaks and observations in the last 5 years. So there's been some duodenoscope-related outbreak infections, especially multi-drug resistant, despite efforts to improve reprocessing practices. And then this problem extends beyond just duodenoscopes and extends to gastroscopes and colonoscopes as well. And then again, biofilm as a persistent challenge for cleaning, and noting that HLD does not reliably eliminate these microbes, especially in the air-water channels where simethicone is often used. And this channel is not brushable, so it's really a problem. And then when outbreaks were investigated, some investigators commonly found personnel either skipping steps entirely or doing them improperly. And there were some urological scopes that have been linked to patient infections resulting from using contaminated scopes, and 3 deaths were reported due to this. There's, again, severe underreporting due to the difficulty in recognizing these infections due to their long latency periods, their inability to trace infections back to the scope, especially, for example, if a patient shows up in their primary care doctor's office. How are they going to know or even be worried about why this patient comes into them with this infection? I mean, they're going to take more of a let's just fix it and move on. And so there's no way to really be able to tell if these are, to be able to track them back unless maybe they come into the ER at the same hospital where the procedure was performed. Then maybe you have a chance if it's been within the last week or 30 days. But otherwise, it's really hard to track all of that stuff back. So endoscopy basics, going into endoscopy 101, for example. So this slide shows you the endoscope anatomy and just how complex of a design it is. You can see it's extremely fragile. There's a lens at the end, light guide fibers and cables moving throughout the entire scope, and then a CCD chip in there somewhere too. And then there are long, narrow channels which are really difficult to clean, almost impossible to see inside without a borescope, and they're really difficult to get dry as well. There's lots of specialty features that different scopes have. Some have that elevator, and then others have an ultrasound transducer at the end, and these require specialty brushes, additional flushing requirements, things like that at the sink. So some endoscopy basics, just to kind of level set. There's various year models of scopes, if you will. So they're kind of like cars, but just not as frequently coming out with new models, I guess. So there's, as far back, there's probably ones well before 140, but I have not even seen a 140 endoscope in my 20 years of endoscopy. So 140s are really old. If you have those, you should probably get rid of them. Same thing with 160s, honestly. I have seen some 160s, but those are usually the older model of endoscope as well. So the 2 most common, at least for Olympus, are 180 series and 190 series, the 190 being the most recent ones. There's different model numbers of scopes that do different things as well. So like obviously an EGD scope is used for an upper endoscope, and a colonoscope is used for colon, and there's different scopes for all different kinds of procedures, which we'll go over a little bit more. Some scopes have water jets and some don't. So just to let you know, some have different features than others. So there's some taxonomy that I also want to share. I wish I knew this a lot longer, or earlier in my career, but this is a way to help you remember what the model numbers or what the model names really kind of mean. So if you see a GIF 190, so that's a gastroscope. The G is for gastroscope, and that is basically the 190 is the newest model, and it involves being used in the upper GI tract. Then the CF, the C stands for colonoscope, right? And it's also the 190 is the newest model, so that can look at the lower GI tract. PCF, the P stands for pediatric, so it's pediatric colonoscope. And again, the 190 being the newest model. If it says 180, then it's the previous model. And that's also for a lower exam. And then a TJF Q190V, that is the most current model of duodenoscope. And that's also used during an upper endoscopy. So the F's can stand for fiber optic. There's some J's sometimes in there. That stands for the water jet. Q can stand for widescreen. If you see a V somewhere in there, like the TJF Q190V, that shows that it's a videoscope. H is in there a lot of times, and that stands for high definition. S stands for short, and L stands for long. So a lot of times the colonoscope specifically will have an S after it or an L after it more frequently. And that's just letting you guys know what those letters all mean in the name. And so some additional endoscopy basics. There's various size outer diameters, or the diameter of the scope insertion tube. And then there's also different inner working channel diameters as well. So not every biopsy channel is created equal. They're not all the same size. They're larger in a regular size scope, they're smaller in a pediatric scope, and so on. There's also a side viewing scope, or a duodenoscope. You can see on the upper right-hand picture that shows the elevator channel, and the elevator is up in the up position right now. And then there's ultrasound scopes as well for GI and for pulmonary. And you can see those down here in the lower right-hand corner. They have that ultrasound transducer. There's a radial up at the top left there, and the linear down at the lower right-hand corner. And then the lower left-hand picture just kind of shows you all of the different diameters, from probably a really small pediatric or bronchoscope all the way up to one of the larger models linear endoscopes. So the 180 series and before that need a waterproof cap in place prior to being submerged for a leak test and for manual cleaning, and ideally for transport as well. So you can see the picture up there shows the 180, what that end looks like, and that you need the cap to go with it. The 190 series, or the newest model there, you don't need to worry about any cap at all. It has that much larger end that goes into the processor, and you don't have to worry about submerging that or anything like that at all. So that's really nice. Let's see, I think that's it for that. So flexible endoscopes can be used for many different minimally invasive procedures. We talked earlier about the EGD, that stands for esophagogastroduodenoscopy. So you can see that it goes through the esophagus, goes through the stomach or the gastro part, and then into the duodenum, which is the duodenoscopy part of it. And then there's the colonoscopy, of course, which examines the entire large intestine, sometimes the very beginning part of your small intestine as well. And then there's an ERCP that stands for endoscopic retrograde cholangiopancreatography, and that is a mouthful, right? But that basically looks at your liver anatomy, and you can sometimes look into the biliary tract, of course, and sometimes even into the pancreatic duct, and looking at that. Then there's endoscopic ultrasounds. You can have the linear or the radial, and that also kind of gets you really nice and close to the pancreas, and oftentimes they'll go through and they'll do some needle biopsies of that, and that helps diagnose pancreatic cancer. And a few other things you can do with it, of course, too, but that's the main thing. And then small bowel enteroscopy scope. Those are very long scopes, longer than a colonoscope, and they are designed to examine the small bowel. And usually they're used with a single or double balloon system is what it's called, and you basically can kind of retract the small bowel back like an accordion kind of, and push forward and view it that way. And it's kind of a very long process, tedious process, usually at least an hour or two of a procedure of looking throughout that entire small bowel that way. And then there's obviously bronchoscopes, which examine the lungs, and cysto and ureteroscopes, which examines the bladder and the ureters. So the procedures can be either screening procedures, diagnostic procedures, or therapeutic procedures. So screening exams are like a screening colonoscopy that everybody should get when they're 45 if you're average risk. Before that, if you have increased risk, or if one of your parents has had colon cancer or even significant polyps. So anyways, during diagnostic procedures, you're usually coming in with a complaint and they're looking for something. With a therapeutic procedure, they know you have a problem and they're going in there to try to treat something. So you can take biopsies or remove polyps, you can stop bleeding, you can dilate the esophagus or the pylorus, you can band esophageal varices or hemorrhoids. You can also place stents, and that goes for both plastic and metal stents. Plastic stents are much smaller, metal stents are bigger, and they're used usually for palliative care for cancerous tumors. And then you can also remove gallstones or sludge during an ERCP. And you can ablate mucosa to treat Barrett's and GAVE, or gastric antral vascular ectasia. So I have some pictures up here of what the normal stomach looks like and what watermelon stomach looks like, and that is the more common term, if you will, for GAVE, or that gastric antral vascular ectasia. And then also the other picture I have is of a normal esophagus, and then of what Barrett's esophagus looks like. You can really see there's a big difference in what that tissue looks like. And Barrett's, you basically get that from frequent reflux, or GERD, gastroesophageal reflux disease. That those stomach acids keep coming up into your esophagus, and you can kind of see what it does. It really kind of wrecks it. And then you can resect small cancerous tumors and do many, many, many more things. But I just wanted to show you a couple pictures since most people probably don't get to see that kind of stuff. So the next thing I'm going to show you is the GIF 2T180, which is a therapeutic gastroscope. Now it is the 180, so it is the previous model, if you will. And it preceded the newest model, which is the GIF 1TH190. Now the big difference between these two scopes is that the 180 series has two instrument channels. It's a 2.8 millimeter and a 3.7 millimeter. So you can kind of have two instruments down there at the same time doing different things. So that's a really big benefit. A lot of doctors really, really like the ability to do that. It can be used with a disposable overstitch system for minimally invasive weight loss procedures, and it's also really helpful to suction large amounts of blood and irrigate the area. You can place clips or do ablations with other disposable instruments. So like I said, it's really nice to be able to go in there and do a lot of different things, like kind of all at the same time. And then the new one is the GIF 1TH190 therapeutic gastroscope. The 1 stands for it being one channel, and as you remember, the previous one was a 2TH, and that means that there's two therapeutic channels. So, but we're talking about the 1 here, and that has a single channel of a 3.7 millimeter, so it's a pretty large channel. And it does have a slimmer design than the previous model of the 180, and it has what's called narrowband imaging, which may aid in the interpretation of certain vascular patterns and blood vessel appearance. So down below on the blue side here of the slide, you can see what regular white light looks like, and when you flip on the NBI, or the narrowband imaging, what it looks like. And you can kind of see just how it kind of highlights the vessels in a little different way that sometimes helps the physician see different things. And then there's a close focus, which allows the examination of the mucosal surface without the need for electronic magnification. And of course, this has the easier setup because there's no need for that waterproof cap that we were talking about. And so it can be used for examining the upper GI mucosa, and it can do therapeutic maneuvers such as polypectomy. It can stop the bleeding and place stents in the upper GI tract. So now we're going to get to the meat and potatoes of this, the urgent communication letter review. So there were three different urgent communications that I'm going to be talking about. One came out in October 18th of 2024, and that was what extended the drying time for that new therapeutic gastroscope model, or what some people call the bleeder scope. So we'll talk about that more in depth. And then the second one came out May 5th of 2025. And that was talking about the eliminating the delayed reprocessing option for the TJF Q190V, which is the newest model of the duodenoscope or ERCP scope. And then lastly, the last one came out in June 24th of 2025, and that was an FDA alert that they issued for certain Olympus products, basically, that have been manufactured in Japan. So we'll talk about all of these in depth. So first thing is going to be the revised channel drawing for that therapeutic gastroscope. So again, October 18th is when this letter came out. There's a picture of that letter on the right-hand side there, and it applies to drying prior to ethylene oxide sterilization, as well as after disinfection for storage. It's the result of some human factor studies that found that clearer instructions were needed, and 16 reported complaints related to this issue. And then they extended the drying time by 12 minutes to purge the water from the channels. And then they ask you to dry each channel in a specific sequence for 3 minutes at a time. So that's 4 channels at 3 minutes a channel, gets you to that 12 minutes. Now I'll say I was confused by this because a lot of the scopes, they talk about a 10-minute drying time. So when they specifically said extended the drying time by 12 minutes, I was like, oh my gosh, are we going to have to dry these now for 22 minutes? Or is it just 12 minutes? So I was confused, so I emailed them, and they did clarify that it is 12 minutes total, not 22. So here's some step-by-step instructions that they outline in this urgent communication letter. First of all, they say that the air pressure must not exceed 72 pounds per square inch for this scope. They recommend that you cover the distal end, cover the control body where the handle is, and the endoscope connector with a sterile, lint-free cloth to prevent any splashing or aerosolization of fluid before you connect it up to the drying machine. Then you set the timer for 3 minutes, and you go to your suction cylinder port, and you hold the control body with your hand and then aerate the suction cylinder for 3 minutes using the timer until it's finished. And then after that, you basically do the same thing over and over again with the air water channel, the auxiliary water channel, and the biopsy port or the instrument channel. So like I said, each one of those things you go through for 3 minutes, and that equals out to a total of 12 minutes of drying time. Then you're going to dry the inside of the suction cylinder, air water cylinder, and the instrument channel port using a sterile cotton swab. So it's important to make sure you have sterile ones and not the multi-pack, which I don't think are sterile. Have to double check me on that. And then wipe all of the external surfaces of the scope with a sterile lint-free cloth until they are fully dry. So here's what some of the additional messages said in there. It said, as far as being a risk to health, that failure to purge moisture from endoscope channels was identified as a contributing factor to ineffective ethylene oxide sterilization, which could potentially cause patient infections, and in rare cases, sepsis or death. Got to cover everything, right? And then they also said to ensure all reprocessing personnel are completely knowledgeable and thoroughly trained on the new water purge recommendations or requirements, excuse me. It's not a recommendation, it's a requirement. And then Olympus urges the reporting of any complaints, including infection or persistent colonization associated with an endoscope, to their Technical Assistance Center and the FDA. Okay, so that takes care of that therapeutic gastroscope. Now we're going to move on to the elimination of the delayed reprocessing for the ERCP scope. So again, this letter came out May 5th of 2025, and it informed users of a correction to the reprocessing manual. So if you received your duodenoscope, prior to May 5th, you received the old manual, and they're not going to send everybody brand new manuals. They're just sending out this letter saying that you need to know that this is an update to the manual, and if you've bought scopes after this May 5th date, that it will include all of this new information. But it's the result also of a post-market surveillance study suggesting higher microbial levels from this scope when manual cleaning was delayed beyond 1 hour and the pre-soak performed. So even when you're following what they had said was the manufacturer instruction for use, if you had to delay for past an hour and you were doing the soak as instructed, they still found that compared to those scopes that were processed within the hour, these were in worse shape. They had more microbial burden on them. And then Olympus no longer includes the option for delayed manual cleaning beyond 1 hour after the patient procedure. Reprocessing manual update to remove the pre-soak from the endoscope. That step is completely removed. And it includes instructions that require manual cleaning to begin within 1 hour after the patient procedure. And they stated that this issue does not affect the functionality of the device at all. And they also acknowledge that there's a remote risk of infection due to dried debris that may not be fully removed, which could lead to a contaminated device. So inadequate soaking, or I don't know, I mean, you're allowed to soak up to 10 hours. I'm sure probably a lot of people don't do that. So maybe they're just eliminating, that risk. And certainly allowing the facilities to take that on if they choose to do any delayed reprocessing. So the warning here says perform manual cleaning within 1 hour. That was added to the reprocessing manual. Pre-soak the endoscope was removed from the manual, and they recommend consulting with your facility's infection control committee if an endoscope could not be reprocessed within 1 hour, and sort of taking a multidisciplinary approach to deciding what to do in that event. They do recommend that facilities have protocols in place to address such situations or consider developing them. And then schedule periodic inspections with Olympus service as well. They say to ensure all reprocessing and endoscopy unit personnel are completely knowledgeable and thoroughly trained on the updated reprocessing instructions contained in that letter. And they also urge the reporting of any complaints, again, to their Technical Assistance Center and the FDA. And at any adverse events with their product use should be reported to the FDA's MedWatch Adverse Event Reporting Program. So now we're on to the third letter. That was the most recent letter, and this is regarding import alerts for certain Olympus medical devices that have been manufactured in Japan. So this again was June 24th of 2025. And it said, basically, despite extensive and ongoing efforts to address compliance issues, the FDA has issued import alerts to prevent future shipments of certain devices from entering the United States due to these facilities not being in compliance with good manufacturing practices. This basically encompasses certain models of ureteroendoscopes, which are used in the urinary tract, bronchoscopes used in the respiratory tract, laparoscopes, which are used in the abdomen and pelvis during surgical procedures, and then automated endoscope reprocessors used to reprocess endoscopes. Failure to meet certain quality system regulations, requirements at AZU, which is a manufacturing site in Japan. The alert does not apply to related products such as replacement parts, connectors, or single-use consumables used within these affected devices or with these affected devices. And if you're currently using any of these devices, you may continue to do so as long as there's no problems, you're not noticing any problems with them. But they want you to make sure you're following the labeling and the reprocessing instructions to a T, and then don't use any damaged devices, of course, and develop schedules for routine inspections of these devices. So the FDA does not recommend that procedures be canceled or delayed without a discussion of the risks and benefits of doing so with your physician. And the FDA recommends complete and prompt reporting of any adverse events so that they can take further action if needed. And the FDA has taken several actions already related to the quality compliance concerns with Olympus and are continuing to engage with them to accelerate the corrective actions intended to minimize patient risk. So here's a list, there's quite an extensive list actually of affected models of various different things. You can see there's 58 entries. I need my glasses for that. 58 entries, and I've taken some screenshots of, I want to say, the first 3 or so, because those are the ones that I felt were pretty much the most pertinent or the ones most often used. So many older scope models are affected, but there are also several of the newer models as well as automated endoscope reprocessors. So you can see here, I have highlighted the Endo iFlex 3D deflectable video scope. Those also look to be newer models, the OER Pro and the OER Mini, as well as the OER Elite is listed here on the second page. And then there's the BF1T180, that's a bronchoscope. That was the previous model of the 180, and then a pediatric bronchoscope and the BFQ180. So all of those are bronchs, but they are all affected and common scopes that are commonly used. And then let's see, this page shows again more bronchoscopes. The P190, these are the 190 models except for that very top one, which is the Q180 AC. So again, the rest of these feature older broncho fiberscopes, rhinolaryngoscopes, intubation scopes, and uretero and renal scopes. There we go. And so reporting problems to the FDA. I've mentioned with all of these, they want you to very avidly report any problems that you're noticing. The FDA encouraged this, all of the healthcare providers to report any adverse events or suspected adverse events experienced with medical devices manufactured by Olympus. And then you submit these through MedWatch, which is the FDA Safety Information and Adverse Event Reporting Program. And I've listed the website here, but if you just Google MedWatch or FDA MedWatch, it's going to pop right up. And like I said, anybody can do this reporting. It does not have to be a physician. It does not have to be a manager. It can be anybody. And here are my references. Thank you guys so much for your time and attention today. Again, happy Sterile Processing Week. You guys really are the heart of the hospital. And we appreciate everything you guys do every day. So thank you again. Have a great one.